During embryonic development, we first have a common atrium. Then the primum and secundum septum start to grow, and they divide the left from the right. We already talked about the left atrium. Now we can turn to the right atrium. We will see what the anatomy of the right atrium is, how to quantify the right atrium, and what pathologic or morphologic changes can be present. The right atrium is located posterior, cranially, and to the right of the heart. The cava superior and inferior enter the right atrium almost in a straight line. The remaining parts of the atria are attached to this tube like a bag. Looking at the right atrium from the front, you will recognize the right atrial appendage, which has a more quadrangular shape opposed to the left atrial appendage, which is more triangular. Which structures are related to the right atrium? The vena cava superior, the vena cava inferior, and the inflow portion, the right atrial appendage, the interatrial septum, and the coronary sinus. When you compare the right to the left atrium in a four-chamber view, you will see that they look very similar. The right atrium is just a bit smaller than the left atrium, and it is divided from the left atrium by the interatrial septum. With color Doppler, you can see the flow of the vena cava inferior entering the right atrium. The subcostal view is also a view where you can nicely see the right atrium. You can see the interatrial septum here and the free wall of the right atrium. With the help of color Doppler, we again can visualize very nicely the inflow of blood from the vena cava inferior into the right atrium. This is an example of a patient who has severe tricuspid regurgitation, where we also see retrograde flow into the hepatic veins and the vena cava inferior. The vena cava inferior is significantly dilated. There are a number of causes why the right atrium can be enlarged. One cause is pulmonary hypertension. Pulmonary hypertension, no matter if it's pre or post-capillary, we often see elevated right atrial pressures, which cause the dilatation. Tricuspid valve disease, in particular tricuspid regurgitation, and right heart failure also cause enlargement of the right atrium. This is an example of a patient with restrictive cardiomyopathy who has severe tricuspid regurgitation. We can see the coaptation defect here in the four-chamber view, and this patient has significant regurgitation. To quantify right atrial size, we can use the length, the width, the area, and the volume of the right atrium. So very similar approach to quantifying the size of the left atrium. Similar to the left atrium, we can also get a very quick reference value for the size of the right atrium by measuring its length. How do we do that? We optimize the image for the right atrium. So you see I'm slanting the septum to get a better contour of the right atrium. Then again, I freeze the image in the moment where the right atrium is at its largest size. Then I simply perform a measurement, again parallel to the interatrial septum, from the annular plane of the right atrium to the roof of the right atrium, and in this case we get 40 millimeters, which again is normal. I can also, similar as the left atrium, measure the area. How would I do that? Very simple. I contour the right atrium and get an area measurement of approximately 15 square centimeters. Again, a normal value. I now want to show you how we can visualize the coronary sinus with echo. This is a parasternal long axis view. The coronary sinus is located right here between the left atrium and the left ventricle, posterior to the posterior mitral valve leaflet. Two-chamber view, orthogonal plane of the coronary sinus, again between the left atrium and the left ventricle. Here we have a classic coronary sinus view. We talked about this view in the How to Image section. This is the coronary sinus. And finally, I want to show you an example of a patient who has a massively dilated coronary sinus, also in a coronary sinus view, because he has a persistent vena cava superior. The normal value for the coronary sinus is 4 to 8 millimeters, with the upper limit being 50 millimeters. What are the reasons for a dilated coronary sinus? We already talked about the vena cava persistence sinistra. Other reasons include an elevated right atrial pressure. Usually you will have a dilated coronary sinus in its portions where it enters the right atrium. And there are, rarely, but there are malformations of the coronary sinus which can also cause dilatation or even an aneurysm. I just want to draw your attention to the fact that we can actually visualize an elevated right atrial pressure because we have a bulging of the interatrial septum to the left, because we have a dilated coronary sinus, we just saw such an example, and also because we have a distended inferior vena cava. Here are two examples of how the interatrial septum can bulge. On the left-hand side to the right, because there's elevated left atrial pressure caused by mitral stenosis. Here there is bulging to the left because there's elevated right atrial pressure caused by massive tricuspid regurgitation in a patient who had both pulmonary hypertension and also massive tricuspid regurgitation. Here are two examples of the vena cava inferior. On the left with normal right atrial pressure, the vena cava inferior is small. It completely collapsed during inspiration. There's almost no lumen visible. On the right-hand side, we see a massively dilated vena cava inferior. The diameter is probably almost 35 millimeters. The normal size of the vena cava inferior is below 70 millimeters. If you let these patients inhale or sniff, you will have a reduction which should be at least 50%. In many patients, you will get a complete collapse of the vena cava inferior, and you might not even be able to visualize the lumen. However, you have to note that some patients have vena cava inferior diameters above 70 millimeters, but they still have a normal right atrial pressure. It's unclear why this is the case. Maybe it's related to the fluid status, but there has also been evidence that patients with orthostatic dysregulation have larger vena cava inferiors altogether. This tracing shows you the normal flow in the hepatic veins recorded with pulsed wave Doppler. The maximum velocity should be below 0.5 to 0.8 meters per second. We have a systolic and a diastolic component. The flow is strongly influenced by inspiration with an increase in velocity towards the heart during inspiration. And we have a retrograde flow component, as can be seen here, back into the hepatic veins. It's very difficult to visualize the vena cava superior from a transthoracic approach. However, there are ways to do it. And the best way to see the vena cava superior is by using a subcostal view, where we visualize the vena cava inferior and then look at the extension of the vena cava inferior. Remember, the inferior and the superior vena cava enter the left atrium almost in a straight line. And thereby, if you use color Doppler, you can see the flow of the vena cava superior into the right atrium. But in reality, if you really want to see pathologies located in the region of the vena cava superior, it's better to perform transesophageal echocardiography. This is such an example. We have a longitudinal view at 101 degrees, and here we can see the vena cava superior enter the right atrium. This would be the inferior vena cava, the interatrial septum, and here this is the left atrium. So pathologies can probably be visualized much better with TE versus transthoracic echocardiography. Okay, so this concludes the right atrium, and now we'll turn away from the chambers to the walls of the heart, specifically to the wall of the left ventricle.